Okay, is this on? Yes. All right. I didn't create any slides for my presentation because it really came out of a conversation that we have been having in our steering group, and also in terms of some of the things I found challenging about participating, not just in guideline panels, which I have been doing now for a while, but also participating in general in the consumer/evidence-based medicine movement. And I think again, I made some reference to this earlier in talking about the challenges of addressing unmet needs, particularly in patient populations like, and here I'm going to talk about men who have sex with men, and of course this affects other people living with HIV/AIDS. And then the issue, of course, of for transgender people who require a lot of health services where there is no appropriate or adequate evidence base. And so oftentimes I found myself struggling between supporting the need for evidence, but also creating access to care for people who are desperately in need of care and who are demanding care even when there is no evidence base to support that care, and where it's unlikely that we're going to have a sufficient or adequate evidence base soon. So that's one of the struggles in that remain unresolved. A good example of that is the issue of the use, particularly for transgender people, in hormone therapies, and the use of different types of hormone therapy that are really off-label. And so this is not cosmetic care for people. This is absolutely life-threatening to them not to be able to transition. And we've had pushback against exposing these patients to potential harm because the studies are inadequate. However, to try and set up a clinical trial for hormone therapy for people who need that care yesterday is really daunting, and to deny them care because of the lack of evidence is daunting, and then to be an advocate on behalf of effective and good and care for trans people that won't harm them without any evidence base is also daunting. So sometimes I feel like I'm caught in the middle. In the guideline panels, and I really like what you did, Lorraine, in the guideline panels that I've served on, one of the things I've seen several times, and now I'm going to talk about the consumers, and this is the conversation that Lorraine just brought up. The consumers who I've sat on guideline panels with, are the consumers I've sat in different meetings representing consumer viewpoints, and this whole issue of, to have or not to have the disease being discussed, or the condition being discussed, or to represent the population being discussed. And more often than not, the conflict of interest that has arisen, I've seen, is between a person's personal experience, maybe with the condition or the disease, or caretaking someone with a disease, and what the evidence base actually says. And several times, in several situations, I have found myself in the position, if I don't have the disease, or I don't have the condition, or I don't personally identify with the specific population, of opposing my fellow consumer in trying to call attention to the position that they're taking not being supported by adequate evidence, because we're there to create an evidence-based guideline. And so that's been, sometimes it's been challenging. And we know that, at least in the guideline panels I've been involved in, we look at the strength of the evidence. We don't just say, oh, if there's insufficient evidence, for so many RCTs, and it doesn't go in the guideline. We look at clinical wisdom, clinical judgment, clinical experience over time, patient preferences and patient values, and also the evidence and the strength of the evidence, which is how I was taught here at Q, to really consider what the evidence base means. But sometimes there has been dissension, because the other consumers have felt very strongly that we need to support things. I'll give you a good example. Recently, we had a guideline that I worked on, where the use of acupuncture was strongly supported by the acupuncturists in the room, and the complementary medicine people, and the other consumer that was in the room, and yet the studies on the use of acupuncture for this particular condition were appalling. I mean, they just didn't exist. And that took us about half a day to resolve about whether to put in the guideline at all, how to reference it in the guideline, how to reference the patient preference for it. And I actually felt like, I felt in a way that folks in the room were kind of missing the point of an evidence-based guideline in the way they were framing the issue as you're for or against complementary medicine, you're not going to give patients adequate access to care. And then recently I did a post on Facebook about, I don't know how many of you saw it, about a new study that came out on patient satisfaction. And one of the interesting things that the study showed was that, in fact, patients, and this is not great news for those of us advocating evidence-based care, that patient satisfaction went up in any healthcare setting or with any provider if they felt that they had unlimited access to any treatment, including the most, unsupported treatment, they wanted it. And if they were denied treatment, or if they were, even if a provider attempted to educate them about the risks and the harms of a potential treatment, patient satisfaction went down. And so there is this sort of persistent issue around, I want to have the care, I'm going to support the evidence base, but I want to have the care I want to have as an individual, and I don't want to be denied anything. And I think the gap there is one that Q has been striving to fill, and that is the difference between patient participation and educated patient or informed patient participation. The difference between consumer advocate or consumer participant and educated or informed and trained consumer participation. And the same thing goes for providers too. So that's my commentary, and those are some issues that we're still grappling with that I just wanted to put on the table. Thank you.